Hey, good morning, everyone. Welcome to COVID Impact 360 Conversations. This morning I have Dr. Robert Groysman. He's a diplomat of American Board of Pain Medicine and the American Board of Anesthesiology. And he's also an interventionalist pain specialist at the Southwest Pain Clinic or Management Clinic. And the other thing he is, which is the reason why I'm bringing him on today, is he's also an author of books on long COVID, which is the clear reason why I have this channel. So, good morning, Robert.
Good morning, Larry. Thank you for having me on.
You're welcome. So, there's always a logical place for me to start these, and that is, I'd like before we dive too quickly into what it is you do in your everyday life now, I'd like to kind of back up a bit and give people a sense of who you are, how you got to medical school, and then how you arrived at the beginning of the pandemic. So, yeah,
Sure.
take it away.
So I'll even go further back than that. I am Ukrainian native, first generation. I came to New York when I was 5, Brooklyn, New York, basically where a lot of the European immigrants end up coming to. And I did my training in New Jersey at Robert Johnson Medical School, and then went for additional training to the University Hospital and trained both in anesthesia and pain medicine. And at some point, we kind of got tired of the cold weather and the 3 feet of snow, and we ended up in Texas. That was around 2008, and established my practice and residence here in Texas. Going forward or skipping forward to the pandemic, or just before the pandemic, which was right around 2019, 2020, I was in the process of doing stellate ganglion block procedures for PTSD. Mainly for PTSD, we found out it works well for this. Being an interventionalist, procedures is what I do. That's my main specialty. And while this procedure can be done for pain management like CRPS, CRIPS, it also showed effectiveness for PTSD. And right at the midpoint of the year, we started seeing patients coming in with new symptoms. They may have had PTSD, but they were having issues with loss of smell, loss of taste, fatigue, brain fog. And for some miraculous reason, these symptoms tended to disappear after the procedure. Now, this was even before we knew long COVID was a thing, or the name long COVID, which was coined later in 2021. But something started ticking in my brain. Something was going on. Nobody really made a connection between fatigue, brain fog, loss of taste and smell. And those were the main symptoms that were coming up at that time in 2020, and why they were resolving post-block. So that's kind of my humble beginnings with long COVID. As I said, it was before even we knew what long COVID was or it was a thing. And some new research was coming out from a doctor in Alaska showing that, hey, he also found that doing these blocks reversed smell and taste problems. And the top two things that we were seeing was parosmia and anosmia. Anosmia is essentially the complete loss of smell, and it was usually accompanied by ageusia, which is complete loss of taste. And the second part was parosmia, which is abnormal smell. And it may be pleasant or unpleasant, but basically you are smelling things that normally would smell different to you. And that's also accompanied with dysgeusia, which is abnormal taste. So it kind of validated what I was doing and thinking. Now, I'm not a researcher, so I don't really have access to IRB or performing placebo-controlled trials or anything. So I was relying mainly on if anybody else heard or seen or experienced the same things I was seeing. So that's essentially how I got into long COVID. As I said, my humble beginnings.
Yes. Well, it would surprise a lot of people, and this literature has just been coming out in droves I'm going to say, the last couple of months. It won't be a surprise to you, but it'd be a surprise to a lot of people that one of the main symptoms of COVID and long COVID is pain, which that wasn't written a lot about over the first couple of years of long COVID. They did
Correct.
all they did all the high level, but so what intrigued me, which is why I reached out to your team, was I'm sure before the pandemic you were not sitting in your chair going, I think I'm going to become an author of books.
No,
and
not at
and I'm
all.
gonna write about my experiences, and I'm going to so that's what the pandemic has done to a lot of professionals like yourself, is that it pulled you into a sector, and hence why I think it was a couple of months ago when you released volume number 1 that I reached out to you and I said, I'd like to try to amplify people knowing that this book is out there. And then you got in touch with me and you said that volume two was out. And I said, great, let's do a chat. Um, so so here we are early in long COVID. Where was that time where you went, I think I'm going to write a book? I think that's where I'm going to start. Never mind
Sure.
5 books.
So the idea came about around 2022. And the main reason was that there were a lot of noise out there, both on social media from doctors, YouTube, from TikTok. You would hear every kind of treatment and cure for every type of symptom you can imagine. It was very disorganized. There was a lot of what I think would be abuse in terms of people coming up with products or protocols or treatments that may not have only been harmful but were costly. And I wanted to review the literature, what was available, listen to everything out there, filter it, and combine it with my own experiences, what I was seeing in my clinic. Because at that point, I was seeing quite a few long COVID patients with many symptoms, sometimes 10 to 15 symptoms, including joint pain, including myalgias and muscle pain, including fibromyalgia type of pain, and a lot of chronic fatigue on top of it. So at that point, I started writing, and I had to start from somewhere. So as I would come across information that I felt would go into one area, I would put it either in the first volume, the second volume, which is dysautonomia, or the third volume, which is mitochondrial dysfunction. Those were the main 3 that I looked at in the beginning. As time went on, I started looking into gut dysbiosis because COVID-19, we know the SARS-CoV-2 virus, does damage our microbiome. And I started including information on basically the gut microbiome. And then I started including a bit more information on MCAS and histamine related issues. And that became the crux of the causes that I look at, which are the dysautonomia, the mitochondrial dysfunction, the gut dysbiosis, and MCAS and histamine. So a lot of the books were written over time since 2022. And at some point this year, I was pretty close to finishing all 3 of them. So that's why they came out so quickly in succession. I was pretty much done with writing them anyway. So after the first book came out, I started finishing up the second book, the volume 2, which is dysautonomia. And right now I'm finishing up mitochondrial dysfunction, which should be out anytime at the end of October or early November. But I am going to take my time longer with the gut dysbiosis and MCAS histamine because those are earlier in the process of writing compared to the other 3.
In layman's terms, or in grade 7 to grade 10 terms, can you share like how you would explain that to a patient who's sitting in front of you? Because one of the problems with a complex virus is that the language gets very complex, and I'm somebody that really likes dumbing things down so people can understand it. I don't think they
Sure.
understand how everything ties together.
Sure. So I did put everything together, but I tried to make these books fairly easy to understand. I know everybody has a different education level and intelligence, but I did try to make the book as easy to understand as possible without losing the substance. However, I've been asked multiple times now to make it even easier to understand.
Sure.
And I'm planning to do that as a simplified version of the first volume. But essentially what I do is, yes, I do look at lab work, okay? And what I'm looking for there is not whether or not you have long COVID, because labs don't help with that, okay?
Yeah, that's
So I
right.
tell patients that I'm drawing your blood, but I'm drawing your blood not to tell you have long COVID. You know you have long COVID. What I'm looking for is for any comorbidities, basically any other conditions that could be contributing to your symptoms. And that could be heart issues, it could be lung issues, it could be your liver or your kidneys, or it could be reactivation of a virus. I'm looking to see if you have chronic inflammation going on or if you have clots. Okay, so that's the first thing. Second, I will review all the symptoms and I will assign them into one of the cause categories. So I have 4 causes, right? And I will assign each symptom to one or more of the causes and then review that list. And once I've determined which one is the most responsible for their symptoms, that's what we're going to treat. So for dysautonomia, the way I explain it is it's an abnormality or problem with your autonomic nervous system. And what is that? It is your automatic part of your nervous system. It does things kind of behind the scenes without you having to directly influence what happens. Things like digestion, swallowing. Once you swallow, you don't control how the food or drink goes down your esophagus, which sphincters open and close and start the digestion process. Your body does that automatically through the vagus nerve. So the vagus nerve is part of our parasympathetic nervous system. It's not the entire parasympathetic nervous system. And I explained to them that there's 2 parts to this automatic system, and one is called sympathetic, which is responsible for fight or flight, and the other is responsible for the rest, the digestion, and healing. So normally when we're walking around, everything's normal, your body is mostly in parasympathetic mode or the rest and digest mode. And you still need both of them. You still need both systems, because without the sympathetic system basically completely being taken out of the picture, you won't be able to maintain your blood pressure, for instance, or your heart rate. So they're still both necessary. It's just who sits in the driver's seat, okay? I think of our body as a car, and they both are in the car, and somebody drives and somebody sits shotgun. So normally what's supposed to happen is the parasympathetic or the vagus, or whatever you want to consider, is the driver, and the sympathetic fight or flight sits shotgun. And when there's a problem, you almost hit in the car, you saw a dog running across your path that you try to avoid hitting, the fight or flight person jumps into the driver's seat and takes over, basically controls the car and has better reflexes, better senses, stronger, and gets you out of that situation, and then jumps back into the shotgun position, the front passenger. And in long COVID, the fight flight guy doesn't want to give up that driver's seat. And the problem is when the fight flight guy sits in the driver's seat all the time, he's not a very careful driver. He's sort of reckless. He likes to speed, pedal to the metal. He steers all over the place. He changes lanes without signaling. He may be quick at dodging cars, but he makes the parasympathetic person very nervous. And driving a car like that long term creates problems, because you're shifting a lot, you're driving it to its limit and even beyond its limit, and that has consequences. So the idea is to get the fight flight out of the driver's seat for the most part of the day. That's really what the goal of dysautonomia treatment is. And it's mostly not oral, okay? These kind of treatments are interventional. You're doing something about it. Sure, you can take symptomatic treatments for POTS, which we'll get, I guess, into later, basically to reduce your heart rate or to increase your blood pressure, which will help reduce feeling like dizziness or you're going to pass out. But really what we're doing is just managing the symptoms. What I'm talking about doing is getting your autonomic nervous system back to where it used to be. And the way we do that is with vagus nerve stimulation. Yes, you can absolutely sing, hum, do breathing exercises, dunk your face in cold water. But my point is we want reliable and consistent activation of the vagus nerve. And you're not going to get that with doing those type of exercises. What we want to do is directly stimulate the nerve. And the easiest way to do that is on the ear. For whatever reason, the way we're created is we have an input for the vagus nerve right in our external ear, and it's relatively easy to stimulate it. You don't need any fancy or expensive devices. You don't need to stimulate it at the neck, because I feel that that is a bit too aggressive. So I feel that doing 30 minutes, about 30 minutes a day versus 2 minutes with a jackhammer or a sledgehammer on your neck is a better approach. So that's the first thing. The second thing is my original go-to, the stellar ganglion procedure. And the way I do it is very different from just about any other pain doctor out there. And lastly is this new procedure that I've introduced from Japan called EAT, and it's epipharyngeal abrasive therapy. And what it is the epipharynx is not a real anatomic structure. We're talking about the area essentially between the nasopharynx and the oropharynx, in the back of your throat and the back of your nose. And the way the procedure is done is by numbing the back of your nose topically using a spray, and then introducing a very thin endoscopic camera through the nostril to the back of the nose, and then introducing a zinc-tipped nasal applicator, and then rubbing or abrading the area. One of the things that I tend to do is also work on the eustachian tube openings, because people who have tinnitus, people who have fullness in the ears, they really benefit from this, okay? And then I look at the nasopharynx and see what happens when I touch it. If it just bleeds by me looking at it, that would be a high grade condition. If it doesn't bleed or do really much, then it's not. So why do this, right? Why do this procedure? Well, this procedure has been done in Japan as part of the regular physicals. They consider chronic epipharyngitis to be an actual medical condition, and is responsible for symptoms like fullness in the head or pressure headaches, issues with the ears like fullness in the ears or tinnitus, problems with the voice, problems swallowing, issues with postnasal drip or facial pressure. Now, it can technically work on most of the dysautonomia symptoms, similar to how the stellar ganglion block does, which I can go into if you like. But its mechanism is a little different. What it's stimulating there is the vagus nerve. And it's a part of the vagus nerve that we normally can't stimulate. It's in the back of your throat. The vagus nerve controls that area. And that area tends to be covered in mucus. And it's really not all that accessible to our immune systems. So even doing something like a neti pot or gargles won't really clear out that area. So any remnants of viral particles or pathogens tend to remain there and continue to stimulate inflammation, low-level chronic inflammation. So part of what this procedure does is it cleans out that area.
Okay. I've spoken to a lot of clinicians, but I won't be able to say I've spoken to a lot of clinicians that have been in this for a long time. I think you've been in it for a long time. There are 3 or 4 that I'm aware of that have been in it for a long time. So I'm kind of framing my question around this. I believe the future of treatment, management, all of that is going to be based around data. And I have to believe that you are ahead of most practices in the world that are trying to manage this process, because you've got the data that's starting to back you up. And that data is going to be gold. I just believe that data is going to be gold. So that must, are you getting asked for data at all? Like,
I
are
have
people trying
not
to get you involved in that?
I have not been approached by anybody to ask me about data. I'd love to. I've been collecting it. Now, granted, I'm a clinician, not academic person in terms of like research, but I
Right.
have been gathering data. I use um, a 10 question questionnaire to assess if somebody, for instance, needs the EAT procedure or not, and if they should continue doing the treatment or not. So that's the first thing. Second, I have both a stellar ganglion and an EAT questionnaire that looks at before and after for symptoms. So these are something that I've developed just out of need to see if what I'm doing is actually making a difference or not. Because if
Yeah,
it's not, why am I
sure.
doing it? So it may start with me reading a study or something that says, hey, this may work. And if I think that there's enough information there that makes sense to me on the mechanism and how things work, then I will create something to measure the results. And yes, a lot of the stuff I do is going to be interventional because that's my bread and butter. I mean, I am a hands-on person. I do interventions. However, even though that's where I started and that's what I still do, I do a considerable amount of counseling and recommendations for oral things to take, such as supplements. Because while dysautonomia is best handled with intervention, and I believe that's a really high percentage cause of long COVID, it's not the only cause. Some people will have more influence from mitochondrial dysfunction, for instance, and that is not managed through interventional means. It's managed through oral or basically supplementation. There are several medications that work. And what I've done, and I've put this in both volume 1 and volume 3. I don't think I put it in volume 2, which is just dysautonomia. But basically what I've created is a 4-step mitochondrial protocol. Okay, so most clinics, most docs will follow something from the FLCCC or similar protocol, or they will work on, sorry, my light went off.
There you go.
It can't see me behind this monitor. Or they will use what I call the bucket method and basically toss a bunch of supplements in the bucket and you take all that and see what happens. And initially, that's how I did it too, because we didn't know any better.
Right. Yeah, of course.
You take a lot of the usual mitochondrial supplements, CoQ10, curcumin, quercetin, resveratrol, alpha ketogluteric acid, alpha lipoic acid. You get the idea. Everything is tossed in the bucket and you just take the bucket every day. But I said to myself, wait a minute, this doesn't make sense because the mitochondria go through a process. If you want to start with basically rehabbing a mitochondrion, you have to do it in a sequence. And that's kind of where my 4 steps came from. And the 4 steps involve the following. Reducing oxidative stress is step 1. So chronic condition like long COVID is going to put you in oxidative stress. That means that there are reactive oxygen species being produced and made that are chronically damaging DNA and fats and proteins in your body. Nothing does that better than our own mitochondria because it's only 40% efficient, which means that even in a perfect world, from a fuel molecule, you'll extract 40% energy out of it in the form of ATP, and the remainder will be heat and byproducts. Now, that's in a perfect world. Of course, if you don't go through the entire electron transport chain to take the glucose molecule or amino acid molecule or a fatty acid molecule and turn it into carbon dioxide and water, which is the end product, right? Sometimes it gets kicked out early. It doesn't go through all the 5 complexes of the mitochondrial electron transport chain. It gets stopped early and it kicks out a reactive intermediate. And those cause damage if you don't neutralize it. Okay? So the first step is to improve our body's ability to neutralize that oxidative stress. And those focus on antioxidants, which are basically reduction agents. If you go back to chemistry 101, something that likes to give up electrons. It's very generous. It hands them out as presents. You don't even have to ask. And those oxidants become reduced because they accept those electrons and they become reduced and they're no longer reactive or causing a problem. So that's the first step, okay? Second step is mitophagy. This is the step where we're going to eliminate those cells that have damaged mitochondria. And the reason that that's an important step is because these cells are a drain on your organs where they exist. They can't divide, they can't perform mitosis, and they can't die using a method like apoptosis because you need a functioning mitochondria to do that. So this step focuses on giving the cell the proper signals to be able to die off and not be a leech or drain on your organs and body. Step 3 focuses on biogenesis. So now that we've gotten rid of some of the damaged mitochondria, let's create some new ones. Now, you can't make mitochondria from scratch. As much as we want to, or people believe we can, you can't. All our mitochondria are clones from the original egg that came from your mother. Sperm doesn't have any mitochondria that are donated to this process. So every single mitochondria in your body is going to be a clone of those original ones. So we have to induce fission, basically creating new mitochondria from old mitochondria. So that's what step
Right.
3 focuses. And the last step is support. So let's make it easier for mitochondria to form. Let's give it components of its double membrane, cell membrane that it has. Let's give it components for functions such as the CoQ10, such as the B vitamins. Essentially, make it easy for it to be made and make it easier for it to function. So that's the onboarding process the first month, and then the second and third month, we just continue the process. But the only difference is step 2, that mitophagy phase. We want to keep it nice and short because we don't want to damage additional healthy cells.
Is it fair to call this a protocol? Your protocol?
It's fair to
Is
call
that
it.
the proper term?
Yes, it's technically a protocol. I have a list in each step. However, you're not taking the entire contents of that step. In other words, each person has been selected to take several of the supplements for a specific reason. You're not taking the entire list each time for each step. The first can easily consist of 100 different supplements. That's unrealistic and
Sure.
ridiculous and not
Yeah.
necessary.
Yeah. I get
But
it.
I make the decision of which supplements should be taken by this particular person based on their symptoms, based on their clinical history, their past history, and everything else, what I think would be the best choice for them. That's where clinical judgment comes in.
Experience.
Yes, that's from
So,
experience. Yes.
so I had severe COVID in August of 2022, which kind of got me into the long COVID advocacy work. I want to see Robert. I want to be your patient. I live in Canada, but I say I believe in what you're doing. How does your practice run? Are you running at capacity, over capacity? Are you bringing on new people? Like, how does the business side of what you're doing? Because here's where my issue is. There is millions and millions of people that need management. There's very few people that have dived into the deep end like you have. Very few. You clearly can't take millions of people as patients. But so how does your practice work? Like, if I wanted to be a patient, could I be? Or do you run at a certain level and you don't take on new until somebody drops out the other side?
I try to help every single person that I can. I wouldn't say
Wow.
overcapacity. I mean, I am booked out quite far. However,
Yeah.
I don't refuse patient care for somebody who really needs it. And we do see patients from all over the world, including Texas. People come in locally. But
Yeah, of course.
I've taken care of pretty much anybody and everybody from around the world except Japan, China.
Well, you brought up Japan. I've posted a lot about Japan, and I've got to tell you, I've never heard of EAT. So that's just a very interesting. When you brought that up, I went, "Wait a minute! I've probably got several hundred posts from Japan, and I'd never heard of that." So
Well, I can tell
that
you
was a great add-in.
a bit more about how I figured this out, but right now it's just me. To bring somebody on, I would have to teach them how to critically think the way I do
Sure,
about long COVID, and that is not an easy task.
absolutely.
This is a process I've developed over the last 4.5 years. Some of it was from trial and error, others was from experience and research. But I believe what I have now is a stable and workable system. And that's also why I decided to publish the books now, because at this point I felt that there wasn't anything new to add to it. Not to say there's not new things to obviously add
Yeah,
to long COVID that's going to be discovered. But I don't know if you remember 2022, 2023, there were a ton of new studies coming out for everything. There was a complement problem, 5A, there was a serotonin problem. I mean, there's
yeah,
always something. There was a thing about microclots at one point.
yeah.
There was a new study coming out every week. Do you see that now? I don't. I mean, I'm on top of anything that comes out that's published, and I haven't seen really much coming out on long COVID that's new. They seem to be rehashing old ideas. but nothing really new. There was a big study. There was actually two studies that came out last year. Gut dysbiosis. There was two different probiotics that were analyzed. One in China, and I forget where the second one was, but and they seem to help with brain fog and fatigue, for instance. So, but there's really not a ton of new information coming out. One thing I think is really, really good about long COVID, as much as I hate it, is it's fostering additional research into chronic fatigue syndrome, MECFS.
Yes.
That condition has been around for many years, and it was very stagnant. There wasn't really any new research being done, and new treatments being looked at. And I think because of the similarity between long COVID and chronic fatigue syndrome, there's more now that's being done for chronic fatigue. So let me go back to the whole Japan thing. I know I started, and I tend to jump around if you don't focus me.
It's okay. It's okay.
So, in regards to Japan, they've been using this for chronic epipharyngitis. As I said, a lot of their physicians feel that chronic epipharyngitis is responsible for many of the chronic illnesses that they see. And they include that as part of the regular visits. And it is covered by insurance, excuse me, over there, but only for Japanese citizens, obviously. And they have shown some success rates with chronic fatigue syndrome using EAT. And there was a study released last year, maybe it was 2 years ago, that looked at long COVID. And it seems to have a connection to dysautonomia, and that's the way it works, in addition to the bleeding that happens, which cleans out the area, and the removal of the mucus that harbors substances underneath. So I went with that. There were 3 studies that were done, and it made sense to me, and I'm already treating dysautonomia, and I'm very comfortable with an endoscope. So that wasn't a big deal for me to incorporate it into my practice. So, but I have not seen anybody from Japan fly in to see me. Pretty much every other country except for, like I said, Japan, China, Venezuela, Cuba, North Korea. Yeah, but pretty much everywhere else, including islands, I've seen somebody from in one capacity or another. I've
And
helped thousands
I'm
of
assuming that you
patients.
do some over Zoom to at
Yes,
least meet
some
somebody.
of it
Yeah.
is done through telemedicine, through a HIPAA compliant
Yeah.
portal,
Right.
not Zoom. It's a different type of
Yeah. Yeah.
device.
Yeah.
But the idea is, yes, I mean, I wouldn't expect somebody to fly in just to talk to me. But I've helped thousands and thousands of patients recover. I don't use the word cure, okay? I don't like
I
it.
like the word recover.
Yes.
I like that word.
So
So
when I've recovered somebody, I consider them in remission, in the same way that somebody who had cancer is not called cured. They're called in remission. So we don't know what the future holds. Nobody does. We're basically, driving this car, and we don't know what the road ahead is. And I may
that's right.
be one of the first cars on the road, but I still don't know what's ahead of me. We don't know if this is going to turn into a chronic illness for a long time, or it's going to resolve eventually based on the treatments.
Well, I use the term a lot that I'm in recovery, but that I could also relapse on another infection.
Right.
Or there's the unknown. And I've posted a lot about this lately, about this whole concept of somebody who's doing fine, they were asymptomatic, and then they got sick. And there was not an explanation to it readily apparent. But in fact, we're learning so much. So I have a question before we wrap up, because it's important to me. I've been in what they call the trenches of disinformation for close to 5 years. What's the one piece of disinformation you think is the most dangerous? I think that's the way I want to frame that, because
Sure.
yeah,
I mean, the easiest way to answer that question is just the use of pseudoscience. Essentially, anytime you have a new opportunity, let me put it this way,
yeah,
for somebody to come in and cash in, they would
a
use
lot,
something that sounds scientific-y, uses a lot of
yeah,
scientific terms and lots of science words, and sounds pretty,
yeah,
but has no basis in science and has no possible way to work outside of the placebo effect, which is real,
yes,
but
I get it.
That's my biggest concern about misinformation. The thing is most of them will be harmless and will just eat through your savings and wallet. But there are few that can be dangerous and potentially injure you or even kill you. And the biggest one on my list would be ozone therapy. And the biggest reason I say that is because you're introducing first a gas that is going to be dissolved in your blood, and it likes to be a gas, and it wants to go back to being a gas. So something like a gas embolus is possible. That's number one.
Yeah, that's new.
Yeah,
So thanks
it
for
was
bringing that
being
up. Thanks for
promoted
bringing that
quite a
up.
bit. Yeah, it was being promoted quite a bit on social media earlier. And the second is ozone is a very strong oxidant. And what did we just talk about? There's already oxidative
Yeah,
stress in your body, and your
sure.
mitochondria are having a hard time dealing with the current mitochondrial. So it doesn't need any help. Your cells and your mitochondria do not need your help to make it more oxidative, to create more oxidative stress. They got enough to deal with on their own. So as soon as it touches the blood, it turns into hydrogen peroxide, which is, ozone is unstable. It's three oxygen molecules stuck together. They don't want to be stuck together, and it's very reactive. It wants to decompose to oxygen and an oxygen singlet, and that's going to become hydrogen peroxide in your blood if it doesn't stay a gas. And you're basically relying on your body to neutralize that oxidant before it can do any damage. Now, we're already on short supply as is. There's three main antioxidants that circulate around your body. I'm not going to go into it, but glutathione is intracellular. That helps keep the reactive oxygen species away from the mitochondria as it generates it. Our supplies of these are low to begin with. Okay, in a chronic illness, you're constantly using them up. So to introduce an oxidant on top of the current situation, to me is irresponsible. If you look out on Amazon or any store, you'll see hundreds and hundreds of different antioxidants, but you don't really see oxidants, right? Get your high grade oxygen here, hydrogen peroxide to eat and take. We don't need it. We don't need it, okay? The only time we actually need oxygen is for the mitochondrial process, right?
Right.
You can't do the oxidative phosphorylation without oxygen because it is the final electron acceptor. That's what we need it for. That's it. It's used in white blood cells to destroy pathogens, but that should tell you something, right? It's destructive. It destroys viruses, destroys bacteria, destroys fungus, it destroys parasites. That's what it's meant to do. Is this something you really want to float around in your system?
Well, there's actually a whole show around pseudoscience and the nutraceutical industry.
Yes.
And I think that you and I both know that there are legitimate, what they call legitimate science trained doctors who have gone to the dark side and are pushing a lot of these types of, I'm not going to even call them cures because they're not cures, but they're
Yes.
calling, their therapies are involved in this kind of stuff. And of course they, surprisingly, Robert, I don't get Christmas cards from these people.
Yeah, I don't either. I don't think they like me very much because I'm kind of ruining their business. But all I'm doing is talking about the truth. If you remember, well, you're not going to remember obviously, but you've seen it in shows. In the old Western towns, you'd have the snake oil salesman come in and
That's right.
show you all the cool cures that their miracle product that they would show
Yeah.
would do. Everything from curing cancer to diarrhea and grow more hair, and you
Sure.
name it. This product here would do it. But that's essentially what it is. They're coming in making claims. They can't back up their claims because they're
But they sound good.
they
See,
sound good. They
that's
sound
that's
scientific.
their
Yeah,
key.
there's several, let me say, patch products that I do not like that are purported to cure just about anything or treat just about anything. Some of them contain stem cells. Because stem cells
It's
like to be
crazy.
at room temperature. They thrive in room temperature. That's why we keep them frozen at minus 80 degrees Celsius normally to keep them alive. But in patch form, they survive no problem. So I think you get where I'm going with this. I could spend a whole week
I do.
nonstop, 24/7 talking
Yeah.
about these things, and we still wouldn't even get through a fraction of the stuff I see out there different wands,
Well,
different lights.
yeah. I'm trying to bring, I use the term pioneer, but I'm going to say the early adopters of trying to understand this condition. So I appreciate your time today. And what I've done is when I go to release this video early next week, I'm going to have all of your book links at the bottom of this. And ask that question about patients because I'm gonna ask your team how somebody would engage with your process because I think
Sure,
that's
it's
also
very easy.
an important function.
We have kind of two different functions. One is through the website covidinstitute.org,
Yeah, I
and the
saw that.
second is if somebody's international. Our system can't handle international calls, so we use a different number and different system to be able to communicate with international people. But we in general try to respond to everybody within 24 hours or less. There's one last thing I want
Fantastic.
to tell you before you go, though, and
Sure.
this is an important message. It's not just for patients; it's also for other physicians who are viewing this. Long COVID has been around 4.5 years now. I remember when chronic fatigue syndrome and fibromyalgia were just in their infancy. And I also remember I was training at this point. I was still a medical student. And I remember how these patients were treated. There wasn't any proof for fibromyalgia or chronic fatigue syndrome. None of the labs came back normal. None of the imaging came back abnormal. And a lot of these patients were treated as either fakers or psychiatric patients or what we call functional neurologic problem. Even back then, that's kind of what set my compass. I said I would never do that to a patient. And I encourage other doctors to not gaslight people. If they feel sick, they're sick. It's not in their head. They're not hypochondriacs. Even if you can't find anything wrong, there's something wrong. Long COVID has a lot of parallels to chronic fatigue syndrome. The labs do not show any abnormalities typically. Imaging does not show any abnormalities in the brain, spinal cord, or anywhere else in the body. Listen to what they're saying. If you're not able to help them, that's okay. But don't send them to a psychiatrist to have them treated for anxiety or depression or some type of psychosis. That is not what is going on with them. If they've had COVID, and even I know we didn't kind of go into the vaccine thing, but some people do have reactions from the COVID vaccines. My point is if you're not able to help them, send them to somebody like myself. I have methods of diagnosing them and treating them and getting them better. Even if nothing looks abnormal, doesn't mean there's nothing going on. And long COVID is one of those conditions, just like chronic fatigue syndrome and fibromyalgia. Nothing really appears on the surface. They look fine.
Yeah.
It looks like it's all in their head, but it's not. It really isn't. These people are really sick. Some of them are bedbound. Some of them lost their relationships with their spouse leaving, being very isolating from their family and friends, coworkers that are able to work. There's a lot of implications here, and to hear that from somebody who they trust as their clinician, that what they're feeling and what they're experiencing is not real, is really, really hurtful and damaging to them because they've already been rejected by their wife
Yeah.
or husband,
Yeah.
their friends. You know what I'm saying?
I here's my take on this. I think if there was a couple of thousand people out there that had these symptoms and had these issues, um, there could be a case for gaslighting. I don't know, but we got 3 to 500 million people. That's a pretty significant amount of people globally that have something not right. So I think my biggest goal is that we need to educate the educators because because that's the top of the heap. If we can't educate the doctors first, then it can't trickle down to the patient. So a big part, almost all of my following are in the sciences, research, doctors, clinicians, you name it. That's most of the people that follow my postings. And I love that part of it because I think we need to educate the educators.
I agree. That's what I've been trying to do for the last 4.5 years,
Absolutely.
and that's
Yeah. Yeah.
what was one of the reasons I'm writing these books and I've written the books, is for have patients take them to their clinicians
Right
and
to their doctor.
right,
Do that.
exactly.
You
And
bet.
yeah, the gaslighting is actually very rampant. I hear it every day, 7 days
Yeah.
a week. I hear from my patients they went to this clinic or that clinic and they were sent here and there. They were tested and they would basically let go. So nothing was wrong. The labs were normal. So nothing wrong with you. Or they'll get sent to a psychiatrist or another specialist to run more tests. As far as we know, there are 57 million people worldwide that have long COVID, but I bet it's 10 times more because some people are too
Yeah, that is.
scared to come forward and say, hey,
Right.
I have long COVID because it's become a stigma. People are laughed at or ridiculed because, again, nothing on the surface looks like there's an illness, even though they feel like crap on the inside and they're not able to work. And why can't you work? Why can't you come to our party or get together or wedding? They're blamed for this instead of saying there's something wrong with you, let's get you help. They're being actually blamed for feeling the way they do. And something you should know, Larry, is I've had COVID twice and I've had the pleasure of experiencing long COVID myself. So, as I always say, I'm not only a doctor, I'm also a client. If you remember
Me
that old
too.
commercial for the hair replacement, he would say, I'm not only the president, I'm also a client.
Yeah.
Granted, it wasn't severe, but I really truly do understand what happens in long COVID, inside and out, for patients. So it's much easier for me to really kind of help the various methods I use.
Well, thank you, Dr. Grossman. I needed to have somebody on like you that could explain these things. I appreciate your time because I know it's valuable. Um, Thank
It
you.
was my pleasure, Larry.
You have a great day.
Thank you.
Bye bye.
Bye bye.